Good afternoon, ladies and gentlemen. I would like to thank the organizing committee of the second World Dysphagia Summit, in particular to Professor Eiichi Saito and Professor Akio Tsubahara, and also the presidents of the 26th and 27th annual meetings of the Japanese Society of Dysphagia Rehabilitation, Professor Koichiro Matsuo and Professor Jun Kayashita, for this nice invitation to participate in this meeting. I'm very honored for this invitation. I'm very happy to participate, and I want to congratulate you for the courage to organize this meeting in times of COVID-19. The topic of my presentation is the triple adaptation of the Mediterranean diet and the design of a meal plan to develop an optimal massive intervention for older people with oropharyngeal dysphagia. My name is Pere Clave. I'm professor of surgery at the Hospital of Mataró and also the director of research and academic development in my institution and the IP of a research group based on neurogastroenterology and oropharyngeal dysphagia. I'm also the founding president of the European Society for Swallowing Disorders and a board member of several foundations. And this slide show all my disclosures. This is a view of my hospital in Mataró, a city 45 kilometers north Barcelona in Catalonia that is affiliated to the Autonomous University of Barcelona, and that is a quite new hospital with a 20-year history, and we are covering a population in the Maresme area of more than 272,000 inhabitants. In this presentation, I want to send you a very positive message, that is that food cures. And let me introduce three Catalan chefs who inspired me for this presentation, that are some of the best chefs in the world, Ferran Adrià, Carme Ruscalleda, and Fermí Puig, who advised me to mix tradition, cuisine, health, and quality of life, and also to thank some institutions who helped me to translate all this philosophy to clinical practice. This slide shows the outline of my presentation. I will start by describing the burden of oropharyngeal dysphagia in older people, then how to perform a massive screening of elderly people with oropharyngeal dysphagia using artificial intelligence, then how to clinically assess swallowing and mastication function and prescribe safe alimentary fluids and texture-modified foods, and how to measure the rheological and textural characteristics of alimentary and thickened fluids and texture-modified foods. And I will try to explain you the philosophy of the triple adaptation of the Mediterranean diet for texture-modified foods and present you some menus and recipes for patients, caregivers, and the role of the alimentary and catering industry. And finally, I will explain you the application of this triplet adaptation inside the minimal massive intervention and the optimal massive intervention. And finally, I will provide you some results of our clinical studies showing the clinical impact of these interventions. I'm sure you know the high prevalence of oropharyngeal dysphagia in older people. Left graph shows the prevalence among independently living elderly people in my city, in Mataró, and we found that up to 27% of patients show signs of oropharyngeal dysphagia, and 15% of them signs of impaired safety to swallow, and up to 6% clear signs of aspiration. At the other end of the disease, dysphagia can reach 51% prevalence among residents in nursing homes, and up to 1/3 of them can present signs of impaired safety of swallows. This high prevalence leads to complications. We found high prevalence of oropharyngeal dysphagia and malnutrition among 2,000 patients admitted in our hospital, and we also proved the high impact on mortality of these conditions, because 1 year mortality was 65% in those patients combining oropharyngeal dysphagia and malnutrition. And we also study the risk, identified that oropharyngeal dysphagia is an independent risk factor for admission for pneumonia, and that 1-year mortality for a patient admitted with pneumonia and oropharyngeal dysphagia is 55%. So this is very serious numbers, very severe complications. This slide shows the iceberg of dysphagia. That is a new pandemic for this century. And although dysphagia has been included in the International Classification of Diseases by the World Health Organization, dysphagia is still seldom systematically screened and treated, and the awareness among the healthcare community is still very poor. This iceberg shows that the patients screened for oropharyngeal dysphagia are still a minority. And it is well known that this year, 16 million US, 30 million European, and 8 million Japanese citizens will present oropharyngeal dysphagia. So many citizens will present the condition. And this slide shows the way that we face the situation. First, by developing an expert system based on machine learning to assess and identify the risk of oropharyngeal dysphagia of all the citizens in our area, including residents at home, in healthcare centers, and in nursing homes. And second, by developing what we call the triple adaptation of Mediterranean diet for patients with oropharyngeal dysphagia, including a rheological adaptation for fluids, alimentary fluids, and thickened fluids, 3 levels of textural adaptation according to chewing and swallowing ability, 2 levels of nutritional adaptation, water, calories, and proteins according to nutritional and hydration status for these texture-modified foods, then an organoleptic adaptation to improve patient compliance and how we translate these diets from to clinical practice, first for patients and then for the alimentary and catering industry. And this slide shows our expert system for massive screening of oropharyngeal dysphagia that will be also presented by Alberto Martin, one of our fellows of our lab during this meeting, and that in summary consists in the individual assessment of the risk of dysphagia, taking into account all the data for the individual electronic clinical records of all our patients. Every citizen has an electronic clinical record, and the psychometrics of this method is very good, and the sensitivity is 0.89, combining this good sensitivity with a quite nice specificity of 0.63. The method is automatic, immediate, and can assess the dynamic risk by repeating the assessment. We combine this screening with 2 very well-established clinical methods to assess swallow and mastication capacity. First, the BBST for swallow that has been recently revisited, and this publication is now accepted, that has 90% sensitivity for oropharyngeal dysphagia and signs of aspiration, and can also provide us the information about the optimal bolus volume and viscosity for each patient. And we combine this information with the information provided for a mastication test for solids and texture modified food. That is a modification of the Thomas method that allow us to have nice information on the mastication capacity of each patient, and also the ready to swallow texture following the mastication process. We combine the results of this clinical evaluation with those coming from our rheology lab, where we can characterize the rheological property of the alimentary fluids and thickened fluids and assess the effect of oral phase and the effect of salivary amylase, in particular in fluids, thickened fluids containing modified starch, and also the effect of bolus flow into the pharyngeal phase by analyzing the effect of shear thinning. And this is the reason that we have developed 3 levels of viscosity based on our findings in the lab, and also in the findings in our clinical trials. This slide shows the results of some of the clinical trials where we assess the therapeutic effect of shear viscosity, and we found shear viscosity is the main rheological parameter linked to the therapeutic effect, and not, for instance, extensional viscosity. There is also a presentation during this meeting where we explain our results in this particular issue, and we always recommend to express the results of viscosity in units of the International System of Units that are millipascal seconds, and to express also in the label of thickened fluids not only the viscosity but also the composition, the dose, the effect of shear thinning of amylase resistance, and also clear instructions for the patients that should use these thickened fluids that are in food for special medical purposes. Also, for solids, we combine the clinical results with those coming from the texture lab, where we use the texture profile analysis to assess the main properties of hardness, adhesiveness, and cohesiveness of food before and after mastication. So we can explore that some properties, such as adhesivity, appears in the post-mastication of bolus. We can measure the changes on these parameters and provide also International System of Units and include these measurements in the description of the texture of the foods, the texture modified foods that we use at the hospital. All these textural properties can be assessed during mastication tests of texturized foods to assess, for instance, the effect of the presence of starch food or the presence of specific foods on the masticatory effort and masticatory capacity of each patient. With all this information, we read what we call the triple adaptation of the Mediterranean diet and the design of a meal plan for older people with oropharyngeal dysphagia based on home cooking by combining texture and thickness for alimentary fluids and texture-modified foods, a nutritional adaptation, as many of our patients were malnourished and dehydrated, and finally, an organoleptic adaptation to guarantee a good compliance. Respecting the viscosity and the texture, we developed these 3 levels for each one, adapting to the chewing ability and the swallowing safety and efficacy of each patient. And we developed 3 levels for thickened fluids, thin, medium, and high, 250 and 800 millipascals, and 3 levels for texture-modified foods, including regular texture and easy to chew texture, also known as a fork mashable, and an easy to swallow texture, also known by thick puree. And we also include a nutritional adaptation according the nutritional and hydration situation of each patient, including calories, proteins, and water volume for hydration. This will be particularly explained in a presentation by our dietitian Alicia Costa also during this meeting. And we developed some materials to explain this to our patients because our initial aim was to develop this adaptation at home to avoid readmissions, and we developed the following video.
Adapting the patient's diet by altering the texture of solids and the viscosity of liquids can make swallowing safer, and ensuring that the diet is balanced and the dishes are presented attractively can make nutrition more effective. When a patient has difficulty ingesting liquids, to avoid aspiration, quantity and viscosity must be controlled. Proper diagnosis will determine the safest and most suitable quantity and viscosity. The desired viscosity can be obtained by using thickeners. Different types of thickener are available. The most effective thickeners have xanthan gum as the principal ingredient. Although there are many viscosity levels, just 2 levels are currently considered: medium viscosity and high viscosity. Viscosity is calculated in millipascals per second, the same unit used to measure liquid pressure. Medium viscosity has a value of 250 millipascals. High viscosity has a value of 800 millipascals. Medium viscosity liquids can be drunk straight from the glass. One example of a medium viscosity liquid is a drinkable yogurt. High viscosity liquids require a spoon. One example of a high viscosity liquid is Greek-style yogurt. If a patient has difficulty ingesting solids or this poses a risk, to help with swallowing and avoid choking and asphyxia, the texture of the food should be adapted. Although there are many texture levels, in practice only two are prescribed: thick puree for severe cases and fork mashable for less severe cases. Thick puree is also called texture C, and fork mashable is called texture E. As well as finding the right texture, the dish must look, taste, and smell appealing. If we always present dishes that look the same, blending all the flavors, the patient will end up getting bored and rejecting the food, and may develop malnutrition. It is also important to follow a high-calorie and high-protein diet to combat malnutrition. Recipes can be supplemented with fortifying store-cupboard ingredients such as honey, butter, jam, oil, cream, and nuts. The doctor or dietitian can also prescribe food supplements available from pharmacies. A puree has the right texture if a plastic dessert spoon stays upright in it, if a fork leaves marks when it is run across the dish, or if the puree does not run through the prongs of the fork. If the puree is too thick, we can add a little broth. If the puree is too liquid, we can add potato flakes, rice or chickpea flour, or powdered cereal. Things to bear in mind are that everything can be blended, that 2 or 3 small dishes are better than one big one, and that it is much more appealing if we separate the ingredients so that the patient can tell what they are actually eating. As we have seen, the best way to treat dysphagia is by adjusting the viscosity of liquids and adopting a 3-way approach to adapting food, ensuring the right texture, fortifying the diet with all the necessary nutrients, and making it look, taste, and smell appealing. More advice and tips at www.furega.com/dysphagia.
We have also developed a website with more than 300 online recipes and menus for patients, caregivers, and families. You can find this website at this direction and use this password to reach these recipes and even an algorithm to use these recipes. We have also developed a cooking workshop for patients and families, a monthly cooking workshop for patients discharged from the hospital, and also a monthly program in a local TV to show all the recipes that we have developed for these patients with a very nice degree of acceptance. This is all the material that we have developed for education of our patients. And we are now in a process of industrialization of these diets for the patients admitted at the Mater Hospital. So we are moving from home cooking and qualitative descriptors to a more industrialized hospital production process that requires quantitative descriptors and measurements to guarantee reproducibility of the diets, and we provide the quality control of the right viscosity and the right texture of these diets from our rheology lab. So moving this strategy to hospital needs parameterization, quantitative measurements, industrialization, and quality control. And these slides show the process where we are. We start with the design of qualitative menus. This is Fernando in this picture, one of the chefs who works at the hospital, who helped us to adapt our recipes to the hospital setting. Also to design quantitative hospital menus, taking into account the medical conditions of our patients, specific conditions such as diabetes or hypertension or other things. And then we started some months ago a pilot production in the hospital kitchen, and we are moving to a pilot production project for selected dysphagic patients. just to achieve the experience to jump to a massive production for all patients with oropharyngeal dysphagia that again needs parameterization and measurement of sensory properties to guarantee compliance. And this line in the lower part of the picture, you can see some of the elements of this process. Again, Fernando is now one of the members of the team, and the connection between the kitchen and our rheology lab, and how to guarantee that the texture and the viscosity arrives to the patient with the good numbers. We have integrated this triple adaptation in a strategy that we call minimal massive intervention. That means the minimal intervention that we should provide to all elderly people admitted and discharged from our institution, and that includes adaptation of fluids according to BBSD, nutritional adaptation in terms of texture, caloric and protein content, and palatability, and provide the nutritional support according to the MNA. This means that nutritional support provided by the nutritionist, and finally to improve oral hygiene that is performed by nurses and our dentists. And by using this strategy, we ran a clinical trial where we found that in the intervention group, the functional capacity measured by the Bartel index improved, the nutritional status improved, and the quality of life also improved at 6-month follow-up. At your right, you can see how survival was 84% in the patients managed by this minimal massive intervention, and only 70% in the controls managed by the standard way. And in the lower part of the table shows that this minimal massive intervention reduced the rate of readmissions, low tract respiratory infections during the follow-up of. We have also exported this triple adaptation to special needs schools for children with neurological disabilities and cerebral palsy, as we found that in Larbos school, that is 3 kilometers away from our hospital, the prevalence of swallowing disorders, nutritional and hydration status, and oral hygiene was seriously impaired. These are the results of a study that we published, that we shown that 90% of these children have safety impairments, and malnutrition and dehydration were very prevalent among these children. So in conclusion, prevalence of dysphagia and masticatory disorders in older patients admitted to hospitals, rehabilitation centers, nursing homes, and living in the community is about 50%, and it is associated to malnutrition, respiratory infections, and poor clinical outcomes. Traditional Mediterranean cooking can be adapted to meet the rheological, nutritional, and hydration needs of older patients with dysphagia, what we call the triple adaptation, and the recipes that we have developed meet the needs of patients with varying degrees of dysphagia and malnutrition, and are reproducible in patient homes. An adaptation of triple adaptation to hospital and health centers, diet production, needs parameterization, quantitative descriptors and measurements of texture and viscosity in international system of units, industrialization, and quality control. Our results suggest that a minimal massive intervention, including the triple adaptation of diets, optimal fluid thickening, and oral hygiene, improves nutritional status and functionality, and reduces mortality, respiratory infection, and hospital readmissions in older patients with oropharyngeal dysphagia. And finally, we believe that minimal massive intervention might become a new, simple, and cost-effective strategy to avoid oropharyngeal dysphagia complications in the geriatric populations. I thank you for your attention and support, and please take care.